Kangaroo Mother Care. Definition: it is a powerful, easy-to-use method to promote the health and well-being of infants born preterm as well as full-term. History: it was first presented by Rey and Martinez, in Bogota, Colombia, where it was developed as an alternative to inadequate and insufficient incubator care for those preterm newborn infants who had initial problems and required only to feed and grow. Components of Kangaroo Mother Care: Kangaroo Position, Kangaroo Nutrition, Kangaroo Discharge and Follow-up. Advantages of KMC: to baby, to mother, to family, to community. Advantages of KMC to the baby: provides effective thermal control with a reduced risk of hypothermia, decreases hypoglycemia, apnea, oxygen requirement and infection, alleviates pain in preterm, increases alertness as well as quiet sleep, attains better weight gain, reduces hospital stay and achieves better follow-up rates, and thus facilitates physiological stability and thus fosters baby's health and well-being. Advantages of KMC to mothers: promotes lactation and facilitates the feeding interaction, increase rate and duration of exclusive breastfeeding, reduces maternal stress, empower parents, stronger bonding, increases confidence and deep satisfaction due to active involvement in care of the baby. Advantages of KMC to family: KMC saves money as the baby is discharged early from hospital and hence father can resume duty early. KMC babies are more healthy and have better IQ. KMC decreases child abuse and abandonment. Advantages of KMC to community: reduces the healthcare cost significantly as KMC saves money on artificial feeds, antibiotics and other medicines, equipment as well as prolonged hospital stay required during conventional care. Eligibility criteria: all stable LBW babies are eligible for KMC. Guidelines for practicing KMC include: if the baby's birth weight more than 1,800 gram, these babies are generally stable at birth. Therefore, in most of them KMC can be initiated soon after birth. If the baby's birth weight 1,200 to 1,799 gram, many babies of this group have significant problems in neonatal period. It might take a few days before KMC can be initiated. If the baby's birth weight less than 1,200 gram, frequently, these babies develop serious prematurity-related morbidity often starting soon after birth. It may take days to weeks before baby's condition allows initiation of KMC. Preparing for KMC. Counseling. When baby is ready for KMC, arrange a time that is convenient to the mother and her baby. The first few sessions are important and require extended interaction. Demonstrate to her the KMC procedure in a caring, gentle manner and with patience. Answer her queries and allay her anxieties. Encourage her to bring her mother or mother-in-law, husband or any other member of the family. Mother's clothing. KMC can be provided using any front open, light dress as per the local culture. KMC works well with blouse and sari, gown or shawl. A suitable apparel that can retain the baby for extended period of time can be adapted locally. Baby's clothing. Baby is dressed with cap, socks, nappy, and front open sleeveless shirt or jabla. The KMC procedure. The neonate should be placed between the mother's breasts in an upright position. The head should be turned to one side and kept in a slightly extended position. This position keeps the airway open and allows eye-to-eye contact between the mother and her baby. The hips should be flexed and abducted in a frog position. The arms should also be flexed. Baby's abdomen should be at the level of the mother's epigastrium. Mother's breathing stimulates the baby, thus reducing the occurrence of apnea. Support the baby's bottom with a sling binder. 2. Monitoring. A neonate's receiving KMC should be monitored carefully. Nursing staff should make sure that neonate's neck position is neither too flexed nor too extended, airway is clear, breathing is regular, color is pink, and the neonate is maintaining temperature. Mother should be involved in observing the neonate during KMC so that she herself can continue monitoring at home. 3. Feeding. The mother should be explained how to breastfeed while the neonate is in KMC position. Holding the neonate near the breast stimulates milk production. She may express milk while the neonate is still in KMC position. The neonate could be fed with paladi, spoon or tube, depending on her clinical condition. 4. Duration. A skin-to-skin contact should start gradually in the nursery, with a smooth transition from conventional care to continuous KMC. Sessions that last less than 1 hour should be avoided because frequent handling may be stressful for the neonate. The length of skin-to-skin contacts should be gradually increased up to 24 hours a day, interrupted only for changing diapers. Discharge criteria. The standard policy of the unit for discharge from the hospital should be followed. Generally, the following criteria are used. Baby's general health is good. Gaining weight, at least 15 to 20 gram per kilogram per day for 3 consecutive days. Maintaining body temperature satisfactorily for at least 3 consecutive days in room temperature. Feeding well and receiving exclusively or predominantly breast milk. The mother and family members are confident to take care of the baby. Post-discharge follow-up. Close follow-up is a fundamental prerequisite of KMC. The infant is followed once or twice a week till 37 to 40 weeks of gestation or till he or she reaches 2.5 to 3 kilograms of weight. Thereafter, a follow-up once in 2 to 4 weeks may be enough till 3 months of post-conception age. Later, the baby should be seen at an interval of 1 to 2 months during first year of life. The baby should gain adequate weight, 15 to 20 gram per kilogram per day up to 40 weeks of post-conception age and 10 grams per kilogram per day subsequently. More frequent visits should be made if the infant is not growing well or his condition demands.